As a quick review from the last presentations, the first presentation was Hospice 101, what is hospice and what hospice is not. And in general, we would say, of course, hospice is a Medicare benefit with Part A for 6 months of life when the prognosis of a patient is that they have a life-limiting illness and they have 6 months, give or take a few months, one way or the other. We know that it is not an exact science, but it is an art, and it is to determine that this patient is approaching the end of their life, and it is an educated guess by the physician making the referral, and then having the patient and the family agree that this is a philosophy of care, that they want to be seen generally at home or the nursing home or the assisted living facility, personal care home, and they want to have their care directed at comfort rather than cure. The second talk that we had was on pain, and pain is a symptom that I think most of us worry about as we approach the end of life. It is that symptom that can really make our lives very, very difficult as we approach death and we're trying to get things in order and we're having pain. Pain can really get in the way of really experiencing closure at the end of life. And I think pain and other symptoms associated with our disease processes are really what hospices really focus on, so that the person can have a better quality of life. And it is about quality. Quantity is important, but generally speaking, most people would say not at the expense of quality. And today, the topic is going to be on the trajectories of death and dying. And the trajectories of death and dying are essentially what happens to the patient, the individual who has a life-limiting illness and then is told to have a terminal diagnosis, a diagnosis that will lead to death, and what happens over that period of time remaining, and in the shape or the curve of the decline. As we stated during the first in-service, we said that good health is just the slowest rate at which we experience the dying process. Every day we lose a little, and every week and every month and every year we begin to experience how we are losing our physical, and hopefully we're gaining something else. And I think we do. We gain wisdom as we get older, and we begin to see that, as the saying goes, some of the sweetest fruit is borne by the oldest trees. And I think as we get older, we do see that when we've lived, I'm 53, and as we get closer, the average life expectancy, as we were saying, is 78, 79 for women and 77 for men here in the United States. As we approach every year, we see every season, come and go, and we begin to see have we really had a satisfying or a good life. And generally speaking, if we have had a good life, I think we can then see a good death, because we have accomplished what we've wanted with our life, and we have lived our life as if today may be our last day here on earth. So we do see that overall everyone wants to have comfort. Everyone wants to be comforted by their loved ones and by the healthcare system, and it's really a right that I think we want to have. We want to be comfortable, and we want to be in control. We don't want to lose that control as individuals, as we get into the medical system, and as we're being treated for initially curative intent, and then when we lose that ability to be cured from our disease process, we then know that all that can be done is to palliate. And palliative medicine is a Latin word that means to cover, and it covers the symptoms related to the disease process that is occurring. And as we know, as we get older, if we miss the prime time for heart attack and then for cancer, eventually we may then find that Alzheimer's or dementia or debility, old age, will then be what will get us in the end. We do have, this awesome medical technology that we have here, especially in the United States, where we can prolong the life at the expense of the quality of life. And when you see that the peak and the number one cause of death is cardiovascular disease, followed by cancer, the next most common cause of death is stroke, then followed by COPD or chronic obstructive pulmonary disease, emphysema, and chronic bronchitis. But if we don't have those illnesses and we live long enough and we live well into our 80s or 90s, we're seeing more and more patients that have end-stage frailty, debility, or old age. And in fact, that does make up the majority of the patients that we see that come on hospice. About 46% of those patients that come on hospice have debility. And we would say cancer compromises about 22% of the patients, and then heart and lung disease is 16%. Sudden illness is 7%, and other diagnoses, liver and kidney failure, is about 9%. So you can see here, if we did a pie-shaped diagram, that it would show that the biggest portion of that pie is frailty or debility. And it is because we do escape the heart, the cardiovascular disease, and we may not escape it, but we have such effective surgeries and treatments for that. And then we also may have good treatments for cancer, and we may even cure the cancer, but eventually we will face overwhelming frailty. And no matter how old we live, it is then the most common problem that we'll face and that we see in hospice care. The trajectory of death and dying, all people do not move at the same speed towards death. If we look at trajectories, we talk about a macro diagram where you would see on the large scale that you have 4 different trajectories on the large scale. On the micro scale, we'll also review today, that is the component that how we respond to the diagnosis of a terminal illness. And so it's very complex. It's like a mosaic. It's not defined specifically in stages, although it has been defined that way, but it's just a mosaic of different experiences, because generally speaking, the type of person you are is a way that you will cope with your coping mechanisms to the disease process that's considered terminal. But first, to begin with a macro scale, the 4 types of disease trajectories were elucidated back in 1965 by a pair of doctors, Dr. Glaser and Strauss, in 1965. And they said that there was the first obvious trajectory is sudden death. Sudden death only occurs about 5% of the times. If you have an accidental death, or you have a sudden heart attack, or you have a major catastrophic event where the person dies in their sleep very suddenly, they have what we would say is a minority trajectory of decline from good health, or actually not good health. They just did not know that underneath that appearance there was a catastrophic illness waiting, and then to sudden death. And the second trajectory that we see is we call it the roller coaster entry, re-entry type of trajectory, that over time the person has an event, they have decline, and then they have improvement, and then they have decline again. And it's a sine wave. It's kind of like up and down, but over a period of time you eventually come to the point of the realization that the person is going to be in the terminal phase of that illness. And that's characterized generally by patients that have organ failure, heart disease, congestive heart failure in particular, COPD, lung disease, liver or kidney disease can also have that type of a sine wave appearance, but in particular the heart and the lung, the cardiopulmonary system, generally gives us that second trajectory. The third trajectory is the trajectory where you have the patient that is diagnosed with cancer, and it's the person's functional status is very good, but at the time of diagnosis with the cancer, you then see a very steady downhill trajectory over a period of a few months. And this was a trajectory that was initially instituted for the Medicare benefit of hospice in 1982, and then it was opened up to other disease processes. So cancer is the classic hospice trajectory where they have a diagnosis, and then in 6 months or so the patient sees that they come to the end of their life. And then the last trajectory is the trajectory where you have the specifically patient with Alzheimer's, dementias, or frailty, where you have a very low functional status to begin with, and then it just happens that they have a very, very gradual, very, very gradually slow, lingering type of trajectory. And as I said, a large part of the population of the United States now, escaping the other trajectories, will see this old age debility or frailty diagnosis. And those are the 4 different types. And just to be able to plan for the patient, the family, and the physician, I think when we know what type of trajectory we're going to likely experience, you can see that the person that goes in and out of the hospital for the second one, where you have the roller coaster trajectory, it's one that the family invests a lot of time in the patient to go into the hospital, out of the hospital, and they get better. And it seems like each time that they get better, they do lose ground. And it is one that really creates a lot of caregiver burden, because you do, and it creates a lot of anxiety of what to anticipate, that it's going to happen again and again. And I think a lot of the educational piece for the patient and family is that, to anticipate and to help them realize what are the likely scenarios to occur, and then at what point in the investment of this treatment process do we say that it's time to go home and have those events treated at home with a palliative hospice approach, instead of an approach where they're treated and then they have to go to the hospital by ambulance over and over, because that's a very, very tiring, very stressful physically type of thing for the patient, especially when they get transported from their home by ambulance to the hospital. So there's a lot of discussions that center around that. You know, at what point do we then now consider staying home, so that then we can have the outreach and have the nurse come see mom or dad at home, or come see me at home. I don't want to go back to the hospital, because when I go to the hospital, it really takes a lot out of me, and it also isolates me. It isolates me from my loved ones. The other trajectory where we were discussing that you have a patient with cancer, that's also a trajectory where there is a lot of anxiety, there's a lot of stress with the loved ones or with the caregiving. They require a lot of help, and I think hospice does a wonderful job, especially with the symptoms related to the cancer diagnosis. In particular, you know, we're experts in pain control, symptom control related to the disease process. It may be anxiety, it may be depression, it may be shortness of breath, it may be nausea, it may be having trouble sleeping. You know, we really focus on those things to improve the quality of life, so that person can prepare for the end with their family and loved ones, and not focus so much on the symptoms that they're experiencing. And then the last trajectory, the one that really places the biggest burden on the caregivers, is a debility trajectory that is a dwindling very slow over a long period of time, and it seems like a marathon, and it is to the loved ones, taking care of their loved one. And a lot of these patients and families really need the support of our social workers to try to make some decisions about respite care, which is part of the service of hospice, where we can give the family a 5-day break in the caregiving. And we can also give them some solutions. They may not be able to take care of their loved one at home. They may need to place them in a nursing facility. They may need to place them in a personal care home. They may need to get some providers to stay home to help them at home. And there's all these creative solutions are there so that we can help the caregiving burden, which is very great when the person's trajectory is very slow over a long period of time. And so on the macro level, that's what occurs, when we have a patient that begins with a very chronic illness, and sometimes this chronic illness accelerates and goes into a terminal phase, and eventually the end of life will happen. And we had said in the earlier series also that physicians are only 38% accurate when it comes to prognosis. We don't have a very good batting average when it comes to being able to say this is how long the loved one has, but we do get more accurate as we get closer to the end of life, and when it becomes more obvious, of course, our accuracy improves. The other thing other than the macro is the micro, or we would say kind of the theories of death and dying, the theories of death and dying, and theories as they relate actually to the stages as were first elucidated basically by Kubler-Ross, and she was talking about 5 different stages in 1969 when she wrote her book. And initially the patient goes into shock with hearing the terminal diagnosis, the bad news. They get into denial. Denial is the protective mechanism. And then they get angry many times, and they bargain. They bargain with God. I'll do this or I'll do that if Lord, you can help me with this. And then they get depressed. And then eventually they have acceptance. But, these are really defense mechanisms and responses to the threat that we have of death. And they were pretty well accepted, and because they do reflect also the theory of development of children and development of human beings, how we develop. But it's a lot more complicated than these 5 stages. And I was looking at a doctor, a physician in Canada, and he actually, I think, has a more realistic staging system, and his name is Dr. Buckman, and he wrote this in 1993. And it depends very much on the characteristic of the person. And he made it a lot easier, too. He said there's really 3 stages broad stages that we can classify patients into. And he said the first stage is the chronic stage, and that's being ill. You're living with the illness. And then the first stage is the facing the threat, facing the threat, and then it's the chronic phase of being ill, and the third one is finally the acceptance. And then out of that, there's a very nice explanation when we do get into the crisis of knowledge, that we're aware of the possibility that we know the diagnosis. Then we get into this phase, we call it the acute crisis phase. You're told the terminal diagnosis, you get into a crisis, obviously, as a human being, and you peak at a certain level, and you peak with that emotional anxiety of knowing the bad news, and then you either go 2 ways. You go the integrated way, where you're together, or you disintegrate. And some people, many patients that we do see, have this sort of chaos where they disintegrate because they don't have their loved ones, they don't have the support. They have a lot of underlying fear and anxiety even before they were diagnosed as being terminal. And now they have this awful burden, and they really are having a hard time coping, and they're not really integrated. And the integration or disintegration can occur all the way until the very end, until the person passes away to the point of death. And this is from an article in 1977 by a Dr. Mansell, and it's called The Phases of Dying. And I think that really describes it one of the best ways that I've studied, because it does give us the mosaic of, as you know, the human aspect, the humanity of how, you know, we don't go necessarily in neat stages, but we go as human beings through periods of you know, calm, periods of fear of death, periods of hope, periods of despair, periods of guilt, you know, periods of just anger and sadness, and then eventually we have the period of acceptance. And depending on who you are as a human being, with your faith, your, you know, the support that you have, the cultural issues or upbringing that you have, the expectancy of a terminal illness in your life. Have you been preparing yourself for this event your whole life? All of this, I think, comes into the equation and really makes a big difference in how you eventually cope. And I normally wouldn't quote a movie star here, some wisdom, but she said something that I thought was pretty apropos for what we're speaking about, and it's actually a quote from Angelina Jolie, and I was surprised to see her say this. She said, "If I think more about death than some other people, it is probably because I love life more than they do." But I think we all feel the same way. I think we all love life, and because we love life, we don't want to let go. And our roots are so deep in this life that when we are called, and we say when the silver cord is brittle and it's about to break, we don't want to let go. We don't want to let go. And it's a very difficult thing for people to, anyone. As we said before, hospice is not about giving up hope, ever. You know, we never give up hope, because hope is the fuel that keeps us going. If we don't have hope, we die. And some people, as someone said, you know, tragedies that they have died before they really have died. You know, they've given up hope, and you can see this lack of hope in them, in the way they, you know, you can just see it in their spirit. They don't have that. And we have some people that are terminal, that have so much hope, that are so alive, and they live every day as if it's their last, and they appreciate life, and they really give that grace of life to people around them. And then we come and visit them, and we are so, you know, impressed and blessed to see someone that is terminal giving us hope. So it is a very special time when people are facing the end, and those characteristics of exactly how we say the speed and the shape at the end of life, and how they're going to cope with their own personal style, and it may be with a good sense of humor, it may be with just doing what they still love to do, and really not giving in to the illness and staying as active as possible. I mean, all of this is something that you know, we would say, boy, makes a huge difference in the quality of their death. And no one wants to die. No one wants to die. We all want to live, and I think it is one of those things that it is implanted in our hearts to live, to be here for forever. And but it's the acceptance and having that peace, being at peace with others, so that we can be at peace and we can be at peace at the end. And the integration, as I said, of our faith and our family and our lives really can integrate at the end beautifully. But if we don't get those things integrated, as the doctor was mentioning here, then you can have this sort of chaos and disintegration. And we try to take it as a human being to help that human being face their death, and then try to give them meaning and give them hope as best as we can. We want to go ahead and answer some questions, and we appreciate your questions that are coming in. And this will be the first question that we have here. The subject is home or hospice. When is home hospice a better alternative than facility hospice, not just for the caregiver, but for the resident or patient? And, I think this is always a really tough issue to answer, because we try as best as we can. I think most families try to stay home with their loved ones. There are many excellent facilities that take great care of their loved ones in a facility, as I said, because there may not be the physical means to care for that person. But if we have the support of the caregiver, and we can anticipate the trajectory, and we can anticipate the investment of the time, the physical time, and the needs at home, I think it can be done many times, and we do. I think most of our hospice patients, probably at least about 80% are at home, probably 20% are in facilities outside the home, and that's just the fact of, the different scenarios that people face. This is a question: when would it be appropriate or necessary for a person at home on hospice to go to the hospital? In one presentation, you talked about hospice in the hospital. That seems contradicting. Would you explain more? It is a paradox many times. We say here in the United States, one of my favorite sayings is that you can have your cake and eat it too, because you can be aggressive in the United States and want to have CPR, but at the same time have a progressive terminal illness and have hospice. We try to not have that dissonance. We'd like to have families or patients understand that the majority of the times we can keep the patient in the home or the nursing facility till the very end. There's only a very few instances where we may not be able to handle a certain situation in the home or the nursing facility. That's very rare, but we do have contract beds in hospitals here in San Antonio where we admit patients, generally because I think one of the most common reasons is that the family does not want their loved one to die at home. And I think a lot of it is because they have children at home. Many of the reasons are that the children are there and they don't want the memory for their children. And it's something that, whether we agree or disagree, it's their decision, and we're not there to really impose what we may think about the situation. But there may be some other instances where someone may need a more aggressive approach if someone's blocked from a blockage, an intestinal obstruction, and we need some sort of treatment that we can't provide at home to decompress the blockage, as an example. We would say that would be probably a good reason to bring them into the hospital, because we cannot treat them at the house. But that's a very rare exception. If people want to stay at home till the very end, most of the time we can do that with relative ease versus coming to the hospital. But you can have hospital care under the hospice program, and we have had experience with quite a few patients in the hospital for different scenarios, and many of those also are patients that are in the hospital already, and they're too unstable to really transfer home. They can be, but the risk is very high that they may die en route, so we may just leave them in the hospital. That's probably the other important type of patient that we would generally elect to keep in the hospital. The next question is, can you give us the title and author of the book once again? And I think we have here Faces of Death. I was talking about Dr. Elizabeth Kubler-Ross and the Stages of Dying, and I forget the title of the book. It was back in 1969. If you Google Elizabeth Kubler-Ross, you can go ahead and get that title. I don't know if you were meaning any other author that I'd mentioned. The other one that I'd mentioned was the doctor from Canada, who also, Dr. Buckman, B-U-C-K-M-A-N, and then the third one was a Dr. Mansell, E. Mansell, M-A-N-S-E-L-L. Are the grief stages a family member goes through? Let's see, I need to see the entire, there, thank you. Are the grief stages a family member goes through related to a loved one's illness and death, the same stages the dying person goes through? How and when should the dying person and the family move toward acceptance? That's a very good question. They're not the same stages because we're all so individual. And we do want to move the entire family towards acceptance. And that's when we have a nice, peaceful, accepting death. Because the critical thing to remember is that if you're going through death and dying as an individual, but your family is not accepting and they're in denial, you're all by yourself. You feel very lonely. And we have seen some people that are imminent. They're maybe a day or two from death, and the loved one is still going to work, and they're just putting the death totally out of their. That's a rare exception, but we do see that where they really exaggerate the denial, and they're not there with their loved one, and then we have to have a meeting and say, hey, your wife is about to die. We need to get you home. It's okay. I mean, we can't force you to leave work, but it's time to be there. And because you can have 10 family members, and if they're all in denial, and they may be watching TV, they may be doing something totally not really what we would say appropriate for the situation, they will make that person that's going through the death and dying awfully lonely. So we do like to have the family all aware, hopefully be on the same page, but that's real hard to do when you have large families. Are there other books about death and hospice you recommend? There are many books, and I did not bring a list of those books, but there's a lot of literature on death and dying, and there's a lot of literature also on people that are ethical dilemmas that I've read, that on both sides, where you have people that are trying to hasten death, and then, the Hemlock Society as an example that was the name has changed, but it's promoting euthanasia, and then you have people that are on the other side of the spectrum, and there's very interesting literature. But there are many books, but I cannot specify one for you right now that I would say. But if you call our office, I'll be happy to do that to help answer that for you. Let's see. The number at the office is area code 210-684-3900. Yeah, area code 210-684-3900. And I'm Dr. Cisneros, and I'll be happy to get those bibliographies or the books that I've read that are very, that have really helped. Let's see, do we have any other questions? Yeah, we're waiting to see if there's any other questions coming up. But I think that I guess to summarize with end-of-life care, we do have a lot of different issues. And I think when you call the hospice company, wherever you may be, they're very happy to help you and to provide literature and to provide the resources and the expertise. And I know all the communities here in the United States, we have hospice companies that do what we do. And I think that really helps the family. You know, the better educated we become, the less fear, the less anxiety we have because we know what we're facing. And I think fear of death is the big issue here. As I said, hospice, we say the H word, people get scared. They get scared because they feel sometimes automatically that it is a death sentence and that there's no more hope. And I think we need to see that in our lives we all live under that death sentence. We're all going to die. And I think it's just a lack of preparation. And the more and the better we prepare for it, the better off we will be. We have, as they say, 10,000 baby boomers that are reaching the age of 65 every day. And so it's a big flux of the age group that is going to be now looking at these issues. When you're at 65, you're on average 10 years away from, statistical average. And even if you live, as I said, to the age of 80 or 90, then you face other medical issues, related to chronic degenerative disease. So the more we prepare, the more we educate ourselves, and the more we see what resources are in your community for yourself or your loved ones, the better decisions you're going to be able